the full utility of NGS testing has not been harnessed yet. I think it's a field that's continuing to move forward and will be helpful at many levels as we go forward. One of the potential, I think, ways it could be used is to identify targets that may not be standard of care in patients who have relapsed multiple times. Additionally, it can identify high-risk mutations like TP53 gene mutations, so we know things like chemotherapy won't work well for patients who have that type of mutation. As far as for selection of the currently approved targeted therapies, I think for tazemetostat, there's evidence that EZH2 mutations do increase the likelihood of patient response. So that's definitely something we check for regularly for patients with follicular lymphoma. And then as far as resistance to treatment, BTK mutations and downstream mutations from the BTK in other cancers like CLL do predict resistance to zanubrutinib, but that same resistance mechanism hasn't been proven for follicular lymphoma. But in the future, with more use of BTK inhibitors in the setting, it'll be important to evaluate that more. Molecular targeted therapy is a very useful therapy in that it's safe and well tolerated for the most part, but I would say the greatest potential is going to come from combinations because the targets or because the treatments are so well tolerated, it allows for combination with additional therapies without causing too much toxicity to the patient. Many of the resistance mechanisms and the reasons why patients relapse after these targeted therapies is that other pathways become active or are selected for in the cancer. So if we start up front targeting multiple pathways, there's a potential for deeper remissions, longer disease control. And I think that combination treatments are just kind of in their infancy in terms of being tested in follicular lymphoma. And in the future, the potential for these therapies has yet to be exploited, I would say.